Thank you for the kind words, sir, and I'm very thankful for this honor. So I'll be speaking on the off-label use of devices and procedures in the posterior segment of the eye. So whenever I think of procedures in the posterior segment, the commonest procedure which I can think of is the use of lasers. Now, Nd:YAG laser is designed for use in the anterior segment of the eye. We've been using it for capsulotomies and for iridotomies. In the posterior segment, the commonest use of this kind of laser is performing a posterior halodotomy. Now, this is done for premacular hemorrhages. We know this is a condition which causes sudden profound loss of vision in individuals, most commonly due to valsalva retinopathy and conditions like PCV. So what we are doing is we are just creating a defect in the posterior hyaloid so as to allow the premacular hemorrhage to gravitate into the inferior vitreous. Now, there are certain complications which can be associated with this procedure. It all depends on how distant the posterior hyaloid is from the anterior surface of the retina. So there have been case reports with the reported occurrence of macular hole, retinal detachments, and even epiretinal membrane formation after performing a successful posterior halodotomy. Another use of Nd:YAG laser in the posterior segment is performance of YAG vitreolysis for vitreous floaters, be it because of a PVD or because of a myopic vitreopathy. Now, we need to be aware of the fact that Nd:YAG laser is basically a photodisruptive laser. So we are not actually ablating a floater in the vitreous, we are disrupting it. So sometimes what happens is that a big floater might get converted into multiple small floaters. So there have been reports when patients have come back with complaints of increased floaters after a vitreolysis instead of resolution of symptoms. Then the known side effects, elevated intraocular pressure, glaucoma, there might be a breach in the posterior capsule leading to accelerated cataract progression. There might be a retinal injury, there might be retinal detachment, and even visual field scotomas have been reported after vitreolysis. Perfluoronoctane, or what we commonly call as PFCL, it's a heavy liquid which is approved for use as a third hand by retinal surgeons during vitreoretinal surgeries, mainly during retinal detachments and during membrane peelings. But off late, we've been starting using it as an off-label device as a tamponade after a retinal detachment surgery. So Dr. Steve Charles has operated more than 1,000 eyes in which he's used this fluid for tamponading inferior retinal detachments. Now, what are the advantages? Firstly, it eliminates the need for prone positioning of a patient after retinal detachment surgery, which is a big benefit. Then also, unlike scleral buckles, PFCL will not induce a myopic shift in the eye. So it's ideal for individuals who've already undergone a cataract surgery or a refractive surgery and who's now had a retinal detachment. So there'll be no change in the refractive status of the individual when we use this instead of a scleral buckle. Then it also does not cause strabismus, pain, ocular surface disorders, corneal damage, and all ocular surface problems which are inherent to a scleral buckle surgery where we do 360-degree peritomy. So it's also been found to be beneficial in patients with inferior nasal and temporal GRTs. Fibrin glue is basically a hemostatic agent which was devised, which has been approved for use as a hemostatic agent in conditions where we cannot control bleeding with sutures or with pressure. But we've been widely using it in ophthalmology in the anterior segment. In posterior segment surgeries, we've now started using it for closing peritomies after doing an encerclage or scleral buckle implantation. And it tremendously improves the comfort level of the patient after surgery. We've also been using it to seal optic disc pits. Now, in optic disc pit maculopathy, we know that it's either the vitreous fluid or the CSF from the subarachnoid space seeping into the intraretinal tissue through the optic disc pit. So there are studies where they've sealed the optic disc pit with fibrin glue and with the ILM and with insertion of intravitreal gas, and it's shown promising results. This is one of the latest uses of fibrin glue they've come up with. These are 2 studies. So what they did was the standard surgery in rheumatogenic RDA is either pars plana vitrectomy or implanting a scleral buckle. Now in PPV, the main disadvantage is this person has to have a post-operative tamponade either with silicone oil or with gas. Now the disadvantage is that silicone oil has its own complications like increased intraocular pressure post-operatively, emulsification, glaucoma, all those conditions, and the patient has to go for a second surgery for removal of the oil. Now, in this condition, what you're doing is you're settling the retina with the air fluid exchange, you're sealing the break with fibrin glue. So after surgery, you do not need to inject silicone oil or gas in the eye. That's a big advantage because from the first post-operative day, the eye would be filled with BSS and the individual would have a good post-operative visual acuity. Recombinant tissue plasminogen activator, it's basically a thrombolytic which has been approved for strokes, infarctions, myocardial infarctions, pulmonary embolism, but we have mainly been using it to treat submacular hemorrhages. Submacular hemorrhage, again, it's a condition which causes a profound sudden loss in individuals who have wet ARMDs, PCV, and we cannot delay treatment of this condition because it causes irreversible photoreceptor damage. So here we've been using TPA either in intravitreal or in subretinal form. Either we can do a vitrectomy and inject the TPA into the subretinal space and then inject gas, or otherwise we can just inject intravitreal TPA along with gas. So both these options have shown promising results as compared to simple observation. Silicone oil, now this is a substance which is approved for use as a tamponading agent after retinal detachment surgeries. But studies have shown, in vitro studies have shown that silicone oil also has a bactericidal and a fungistatic activity for over a period of 30 days. Now, this quality of a medical grade silicone oil has been exploited in treating post-surgical endophthalmitis and post-traumatic endophthalmitis, even in the pediatric age group. So this has shown, again, promising results in eyes as compared to the ones which were not injected with silicone oil. Human amniotic membrane, it's one of the inner fetal membranes which has its own inherent anti-angiogenic and anti-inflammatory properties. So we've exploited this property in treatment of large refractory macular holes in which photoreceptors have been seen to show migration after sealing of breaks, and the results have been better as compared to non-usage of amniotic membrane in refractory macular holes. There have been reports of this complication. It's parafoveal atrophy, which was seen after usage of this graft, but then it was seen that it was seen in individuals only in the myopic eyes. This study only had myopic eyes, already had myopic macular degeneration. So this might not be the case in the rest of the eyes. So this is one of the recent usages of amniotic membrane. Then this is a very interesting usage of, again, human amniotic membrane. Now, in fractional retinal detachments and in combined RDs and diabetics, whenever we operate, we always land up, most commonly, we do land up with some iatrogenic macular holes. Now, these RDs have a very thick subretinal fluid. So even if you aspirate the fluid, it will never be complete. So it's what we end up with is doing an extra amount of laser around these breaks, which subsequently leads to PVR formation and recurrent RDs after the surgery. So using an amniotic membrane to seal these breaks without laser retinopexy drastically improves the outcome in the form that it reduces the incidence of epiretinal membrane formation after surgery and therefore reduces the incidence of recurrent RDs in these cases. Ozurdex, as Colonel Gaurav sir already mentioned, these are the approved usages, but in RD surgeries, it has of late been used to prevent PVR. So wherever we think that this case is more prone to have PVR postoperatively, we have been using Ozurdex implantation we've been doing along with silicone injection in such eyes, and it has shown good results. Another recent usage of Ozurdex is subconjunctival injection of Ozurdex in eyes that have anterior scleritis of a non-necrotizing variety. The advantage of procedure is that you can always remove this explant if ever you see any complications like raised IOP or necrosis of the sclera. Then suprachoroidal buckling is again a recent procedure. Now what we do in a sclera explant is we are indenting the sclera from outside to bring about a choroidal adhesion. This concept involves just making a small sclerotomy and injecting a filler into the suprachoroidal space. So now you're indenting the sclera to oppose retinal break with the underlying RPE without the inherent complications associated with the scleral buccal placement. So we are using different types of cannulas which have been devised and different types of hyaluronate depending upon the duration of indent that you need to see in these eyes. And lastly, photodynamic therapy. We know it's approved for use in CNVM associated with ARMD, but of late we know as it specifically targets choroidal vasculature, we've been using it for treating very effectively polypoidal choroidal vasculopathy, vasoproliferative tumors, chronic CSR. It's been proved to be very effective in chronic CSR and also in choroidal hemangiomas and in peripapillary CNVM. So that's all about off-label uses in posterior segment. Again, to conclude, I would say that whenever a drug is being or a procedure is being done off-label, we know there are only two things. Either it is with the aim of treating the patient when you just need to take a consent from the patient and you're backed up with sufficient medical literature. The other is you're experimenting with the patient. In that case, you need to have a proper legal backup. You need to have an ethical approval to do such a procedure. Thank you.